Well, let's review chapter 51. We're going to be looking at diuretic agents, and as you look at diuretic agents, there's a couple that we're using quite a bit that you need to be familiar with. There's a gopher in the back. Hang on. Chapter 51. As we're looking at chapter 51, which is diuretic agents, there are some that you will need to know for the rest of your life, and let me just give you those highlights as we go forward. Number 1, hydrochlorothiazide, HCTZ, hydrochlorothiazide. You also have furosemide, which you might be familiar with is called Lasix, but furosemide is also a very important one, as well as spironolactone, bumetanide, and then the last one is mannitol. Mannitol is an extremely important drug that we use to decrease cerebral pressure, decrease that. So I wanted to make sure that those key prototypes are highlighted for you first before we go forward. Now in chapter 51, you'll note that we have look at the safe medication administration on page 877. As you're looking at this, let me make it bigger just really quick here. As you're looking through safe administration, key points, and it says right here in the book, some patients decrease their fluid intake because they don't want to go to the bathroom. Diuretics make you urinate. And so we need to educate patients that they still need to take 8 to 10 full glasses of water, even though they're on a diuretic, to decrease their water. Some people, daily weights are important for patients who are getting diuretics because we're watching how much fluid is being kept in their body. So the most accurate and the most sensitive reading of if a person is retaining fluid is their daily weights. Some people can lose up to 5 pounds in a day just from using a diuretic, so keep that in mind. So safe administration. Now if you're thinking that a patient is getting up and going to the bathroom quite a bit, there's an issue with that in safety. So we want to make sure that our patients know where the call light is, they call for help in order to get up. And so those are important concepts as you're looking through diuretics, that we want to keep our patients safe. So let me go to the PowerPoint slides. Chapter 51. There's different classes: thiazide, loop diuretics, potassium sparing, osmotic diuretics. Those are huge ones as we go forward. And so we're going to be increasing the amount of urine that's produced by the kidneys and increase sodium excretion in order to decrease the fluid that's in the body. Now I'm looking over here because my dog's in the kitchen and there's a gopher that's taunting my dog, so if you hear my dog bark, I'm sorry. So, indications for diuretic use. On slide number 4, we have edema associated with congestive heart failure. This is a real classic utilization of diuretics. Congestive heart failure, CHF. When you have your right-sided heart failure, remember this from patho, right-sided heart failure, rest of the body. You have a backup of fluid you have ascites, you have dependent edema. When you have left-sided heart failure, remember left means lung, and you have backup of fluid into the lung. So edema associated with congestive heart failure can either be within the body or within the lung. And acute pulmonary edema will be caused by left-sided heart failure. Liver disease is also there, renal disease, hypertension, and let's go forward. Slide number 5 just reminds you of the sites of action. Some are called a loop diuretic, and that tells you that it works at the ascending loop of Henle is where that mechanism of action will be. Osmotic diuretics work right there at the nephron itself. So as you're thinking about your drugs, knowing where it acts kind of helps you understand their process. Slide 6. Thiazide and thiazide-like diuretics, they have thiazide at the end. Note hydrochlorothiazide, or that is HCTZ. Hydrochlorothiazide is the number 1 there. Block chlorine pump treats CHF, liver or renal disease on slide 7. Slide 8. Of course, allergy to sulfonamides, thiazides. But keep in mind that fluid and electrolyte imbalances are going to be a key thing with these drugs as well. We're going to be watching specifically with any diuretic. You think about, we're watching potassium levels. And so we want to make sure that their potassium levels, remember potassium 3.5 to 5 or 5.5 depending on what your hospital is, but 3.5 to 5 is classic. When we're looking at potassium, the reason why we're watching this is, number one, some of these drugs waste potassium, but also potassium is so important with that heart function. If you have too much, remember, you can have the heart stop. If you have too little, you can have an arrhythmia. So we're watching this potassium level to make sure that we have it within good limits. So your prototype, slide 11, has hydrochlorothiazide, and it tells you the reasons why we used it, which is here. Its onset is 2 hours, and it peaks at 4 to 6, and then it lasts for 12. So hydrochlorothiazide is a real classic diuretic that'll be used. We're going to be watching with these patients for hypotension, dizziness, there are fall risk, those types of things. So let's get into slide 15. Loop diuretics, Cymide or Tenide, furosemide, Lasix. So what's interesting is your patient will say, oh, that's my water pill. Well, try to get them away from saying water pill. This is your diuretic, so that they can have the understanding of the fact that it's more powerful. It's most commonly used. It says bumetanide or Bumex is more powerful than Lasix. So keep in mind, sometimes you'll have furosemide ordered, sometimes you will have bumetanide. These waste potassium. So we're going to be watching the potassium level, as well as if we give this IV push, it does act very quickly. So before I get ahead of myself, slide 16 tells you the action. It's on the ascending loop of Henle. We're watching for electrolyte depletions. Caution with SLE, systemic lupus, erythematosus, gout, diabetes. And so furosemide is there. Note on slide 20, furosemide, when we give it IV push, its onset is 5 minutes, it peaks in 30 minutes, and it only works for 2 hours. You can see when we give furosemide IV push, and you're watching that urine bag, if they have an indwelling catheter, you're watching it for urine production. You're watching it for urine production. You will see it fairly quickly. And so furosemide, also teach your patients to take this in the morning, especially if they're alert and oriented and they're getting up to the bathroom, because they're going to be going to the bathroom all the time. Please don't profile this at night, because it's going to keep them up all night and they're going to be more of a fall risk. So going on to slide 22, we have carbonic anhydrase. This we don't see quite so often, and I didn't even list it when we were before, so don't worry about this drug. Potassium sparing diuretics, slide 28. So when we look at diuretics, we just talked about the furosemides. They waste potassium. So let's see what we can do in order to maintain potassium levels without having to give potassium supplements. Because remember, those potassium supplements are big horse pills. You can break them in half, mix them with applesauce, but they're still a pain for your patients to take. So potassium sparing is a great thing for these types of patients. And your prototype on slide 30 is spironolactone. And note that it's oral. And it takes a long time to go through. Sorry for the pause. My brain stopped for a minute. So it blocks the effects of aldosterone in the renal tubule. So if this is not something that's going to give you that immediate diuretic effect like a furosemide does, but this is something that can be oral and it can help maintain your electrolyte balance. And finally, on 32, you have your osmotic diuretic. It pulls water into the renal tubule without sodium loss. I mentioned this already. You're going to see this with increased cranial pressure, ICP. This drug reduces the swelling within the brain, so you can think of traumas, TBIs, traumatic brain injuries, those sorts of things. And so We're not going to use it for intracranial bleeding or dehydration, CHF. On slide 33, sudden drop in fluid levels can happen with mannitol. Nausea, vomiting, hypotension, lightheadedness, confusion, headache. Those are side effects. What's interesting about those, however, is those also can be side effects of increased intracranial pressure. So the nurse has to be very discerning about what's causing this side effect to happen. Your prototype, mannitol. Mannitol. And I'm looking to see where the nursing intervention is for mannitol is IV, onset 30 to 60 minutes, peaks in an hour. Hypotension can be an adverse effect, dry mouth, anorexia. It does not have the consideration of this. It needs to be hung with a filter because mannitol crystallizes at room temperature. So when pharmacy sends it to you, it should have the filter that's rubber banded to it so that you can hang it appropriately. Across the lifespan, children many times utilize these types of diuretics for heart conditions. We're on slide 37, I'm sorry. Adults sometimes are utilizing diuretics in conjunction with an antihypertensive in order to control their blood pressure. So they can be on it for a long time. It says here right on this slide what I said earlier, weigh themselves daily, because that is the purest indication of if you're retaining fluid or not. And you can catch it early before those lungs start to fill up and you start having side effects of having dependent edema. Older adults are fall risks. And so that is the end of the PowerPoint slides for Chapter 51. If you could hang on with me for one more moment, I want to swiftly go through and see if there's anything else that I really want to highlight in the book. Make sure you have the right name. There's a great critical thinking scenario for furosemide on page 863 if you'd like to have this explained a little bit more. However, on page 864 there's great patient teaching for furosemide. Be sure at the end of each chapter to look at the questions that are there. They can guide you in making sure that you have a good comprehension of what you need to know for, not only for the exam, but for your nursing practice, because diuretics are such an important drug classification. Oh, okay, so on page 868, nursing considerations for patients receiving diuretics. I also wanted to talk about skin turgor. You can get dry skin, and if the patient isn't drinking fluids, you can appreciate how you can have impaired skin turgor as well. Let me go to the end of the chapter here, and there's a great summary. So, review the nursing implications for diuretics, and you're going to be good.